Are you currently pregnant and thinking about breastfeeding? In this video, I discuss a few of the tips and tricks that I really recommend you know about before you start your breastfeeding journey.
Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
Good morning. So we are back here at Be Kind Pediatrics, and today I wanted to talk a little bit about breastfeeding since our last episode was on formula. And I want to review today kind of the topics that I like to review with my patients in prenatal sessions. So I usually recommend most of my patients have at least 1 or 2 prenatal sessions if breastfeeding is part of their birth plan, to really review the basics of breastfeeding. Because I find that once you're in the hospital, a lot of the initiation of breastfeeding happens within that first hour, what we call the golden hour. And it can be helpful to just have a general idea of what a typical latch looks like, what are different breastfeeding positions, how do you initiate breastfeeding. And so we're going to review some of those topics today. And then we're also going to talk a little bit about the most common breastfeeding myths that I encounter in my everyday practice. Okay, so since we started off by talking a little bit about the first hour after delivery, what is often referred to as the golden hour, this is really where the breastfeeding journey begins for a baby mother dyad. And so again, this first hour after delivery or immediately after the baby is born, it's really recommended that the baby goes skin to skin with mom. So that means unwrapped completely, no blanket, maybe just a diaper, mom is bare-chested, and you can put the baby, imagine this baby doesn't have clothes on, but maybe just the diaper, chest to chest with mom and a blanket around the baby's back. So what are the benefits of skin to skin and why do we recommend it? Well, first off, for breastfeeding, uninterrupted skin to skin improves your colostrum production. So it makes for a more successful initiation of breastfeeding. It also has lots of benefits for babies. So babies who do skin to skin often have reduced crying, they have reduced cortisol levels, it helps them regulate their temperature as well as their heart rate. It helps boost their immune system, it reduces postpartum depression and anxiety in mom. Studies have shown that babies, again, who do uninterrupted skin to skin have better weight gain. And it doesn't just have to be mom. So skin to skin is also great to get dad involved. So I usually recommend that dads wear a button up into the delivery room, something they can easily unbutton, and also place that baby belly to chest after delivery. And so what we're really looking for here when we say uninterrupted skin to skin is that the baby is put to the chest naked and that they initiate breastfeeding on their own. So babies usually go through 9 stages when they are first born within that first hour if they are put to skin. They kind of let out their first breath or cry, then they calm down, then they awaken, and then they will crawl slowly to the breast and often self-latch or initiate breastfeeding. If that doesn't happen, if the baby doesn't latch on their own, that's okay. What I then recommend is that mom hand expresses a little bit of colostrum just to get that going. So I want to pause here and talk a little bit about safety during skin to skin. So if you've just gone through a really long or prolonged labor and you are exhausted, it is more important that you are able to do skin to skin safely than you just do it. So what do I mean by that? I mean, if you're too sleepy and you're at risk of falling asleep, forego skin to skin. It's much safer for your baby to be in a safe environment than for you to have gotten that 1 hour of uninterrupted skin to skin. So wait till you're a little bit more rested and awake. I definitely recommend that you have a partner watching you during skin to skin in case you do get sleepy. It's good to have a blanket around the back of the baby, but make sure that there's nothing obstructing the mouth. Again, when you have baby tummy to chest, you want to make sure that their head is rotated to the side so that their nose is nice and open and their airway is nice and open. The next topic I usually talk about with parents in the prenatal session with breastfeeding is proper latch and how to set yourself up for proper latch. So, if you have baby and this is your breast, what you really want to do is first, again, get the baby totally undressed, just in a diaper. You want the baby's ear, shoulder, and hip to all line up in one line. So what you don't want, and is common, is something like this, where the baby is feeding at the breast sideways, and that their ear is not in line with their shoulder blade and hip. So again, you kind of want everything lined up in one line. Then you want to take the baby in a C hold. So you want your arm and thumb to make a position like this and support the back of the neck. And so your palm winds up kind of being in the shoulder blades. It's very common and natural for parents to want to do something like this when they're breastfeeding, but babies have a reflex where if you kind of push their head in, they automatically push back, and that can really disrupt the latch. So you want to go below the neck with a nice C hold, palm below shoulder blades, and then you can support their bum depending on the position that you're in. So you have this nice C hold with the baby, and then you are going to take, again, depending on the position you're in for this demonstration, I'm going to demonstrate a cross cradle hold. You want to, with your free hand, again, make that C shape with the breast. So you're going to make a shape like this with your fingers, and you're going to come underneath the breast and around it and compress slightly. And then you have baby. And again, you have a nice C hold here with your hands supporting the back of their neck. And so what you're going to do is take baby, and you want to aim the nipple for the nose. A very common kind of misconception is that you want to put the nipple in the baby's mouth because that's what bottle feeding looks like, but that's actually not what you want to do with breastfeeding. So what you want to do is take the nipple, the baby, put their nose to the nipple, and what they will naturally do is open their mouth and let their head lean back. This is another reason why it's important to give them the room to move their head a little bit. So their head will naturally kind of fall back and they will gape open with their mouth. So I'm gonna put baby down for a second. So again, you have your C shape on the baby's head, C shape with your breast. You're putting the nose to the nipple. They're gonna let their head fall back and gape open. When they gape open, another common mistake is to bring the nipple or the breast to the baby. You want to bring the baby into the breast for a nice deep latch. So you're going to bring the baby in to the breast. The bottom of their chin should be touching the lower part of the breast. When their head falls back, they will latch on up like this. And so that would be kind of what a good latch would look like. And if you think about it, in this position, the nipple is at the top or the roof of the mouth, which helps the baby initiate a suck. I don't know if you've ever done this before, but if you put a finger in a newborn's mouth, a pacifier or a bottle, if you tickle the roof of their mouth, they will start sucking. That helps them initiate that suck reflex. You'll notice the baby has a good deep latch. If their chin is kind of touching the breast, their nose is a little bit free so that they can breathe. The baby should be taking a large part, not just the tip of the nipple. Again, that's kind of a common misconception, but they will take almost the entire areola, definitely the bottom portion more than the top portion. So they have a little bit of what we call an asymmetric latch. That's normal. That's a sign of a good latch. And their chin, again, will be touching the breast. Then what you're looking for once the baby latches is that their lips are flanged out, not tucked in. So they should kind of be pursed and out, that they have a nice rounded cheek line, like this baby. There's no dimpling in their cheeks. And their mouth should be open fairly wide. So we're looking about at 180 degrees here. If your baby's mouth is only 90 or 45 degrees, they don't have a wide enough gape. They're not getting a deep enough latch to get adequate milk transfer. So the next common question or the next common topic I'd like to address with parents are establishing a good supply. So milk is basically made when the signal to the brain to make milk happens twofold. So one, stimulation of the breast and areola. So a lot of newborns, you'll notice, kind of like caress the breast with their hands. That's them sending stimulation to the brain, a message to make milk. And then the actual suckling. So that requires having the baby's mouth and hands be able to touch the breast entirely. And then the most important aspect potentially is frequent removal of milk. The more often that milk is removed from the breast, the more your body will make. And so you really want to make sure you're not missing any feeding cues and getting your baby to the breast when they are hungry. And sometimes when babies are going through a growth spurt, they'll cluster feed, meaning they'll eat very frequently. And that is them, again, frequently removing milk to send the brain the signal that they need more milk because they're growing. So then the kind of follow-up questions to that is, well, how do you know that your baby is hungry? So there are a few cues that your baby will start to show that they're hungry. Often they will take their fists and put them in their mouth. They might be looking side to side and gaping with their mouth open. Sometimes they're actually searching for the breast. These are kind of early hungry cues. As the baby gets more hungry, they will start to get more frustrated. So they might do things like lip smacking, and then eventually they will start to get frustrated and cry. Once the baby is to the point where they're crying and they're really frustrated, I usually recommend getting the baby nice and calm before you have them latch, because often a frustrated and overly hungry baby will latch really hard, and that can cause nipple soreness. So try to get them calm before you go to have them latch to the breast if they're at that stage. So kind of the converse of when are they hungry, how do you know that they're done or full? So the most obvious sign is that the baby will relax. So their fingers might open up a little bit, their body will relax, and the suckling will start to decrease or stop completely. Some babies will detach themselves from the nipple when they fall asleep, but some will not. They'll just stop sucking. So if the baby is done and they're still on your breast but not sucking anymore, you can just take your finger in the corner of their mouth and break the suction and remove them from your breast. The next topic I usually talk about in this prenatal visit is breast engorgement. I think it's really important, especially for moms of C-sections, to know about. So breast engorgement is when the breast is really hard, tender, the nipple can stretch, the skin can stretch, you can get some dimpling. So when the breast is that hard, it is really difficult for babies to latch onto the breast. And it also puts you at risk for clogged ducts and then mastitis. So it's important to know about because mastitis is a life-threatening infection of the breast. And I say moms of C-sections, but any mom with prolonged delivery or mom with C-section or any mom during labor and delivery who received a lot of IV fluids are at higher risk for getting engorgement and delayed engorgement. So usually milk engorgement, if it's going to happen within the first week, happens within the first 3 to 5 days. But research has shown mothers with C-sections, that's a little bit of a delayed risk. So they are at risk for engorgement up to 7 days in the initial period. And then afterwards, anytime you're in a position of oversupply. So again, what engorgement looks like is going to be a hard, tender breast. The skin might be stretched. The nipple might flatten out and become hard, again, making it difficult for the baby to latch. So how do you start to address engorgement in those first couple of days if you're noticing it? So the first thing you can do is just put a warm towel on your breast. Definitely massage your breast. So you're going to do circular kind of massage starting at the top of your breast and down and moving downwards towards the nipple, kind of moving that milk around and removing any of those clots. Then I usually recommend hand expressing just a little bit until the milk starts going so the breast softens up and it's easier for the baby to latch on. You can also try reverse pressure, where you take your finger like this on the top and the bottom of the breast and press back and hold for 30 to 60 seconds and then kind of move around the breast to do some reverse pressure. And again, pushing that fluid from the tip of the breast back to the upper part of the breast in hopes of kind of getting the breast soft enough so that the baby can latch. Another trick you can do is something called reverse pressure. So you can take your fingers in the top and the bottom of the breast and push back and upwards. You want to hold it for 30 or 60 seconds and then move around. That can help push the fluid back up into the upper parts of the breast, making it easier for the baby to latch. And then the most important thing is to put the baby to the breast frequently when they're hungry to help them to get them to drain some of that milk out. So not only does engorgement put you at risk for clogged ducts and mastitis, but it also puts you at risk for decreasing your milk supply. So remember in the beginning, I was kind of talking about how supply is really dependent on removing milk. So the more milk that is removed, the more milk that is produced. If milk is hanging around in the breast, it is sending a message to your brain that we don't need more milk, and it will decrease your supply. And so it's something that if you notice, I recommend that you get in touch with your lactation consultant right away, and B, that you start thinking about some of these maneuvers. When we're speaking about pain and tender breasts, It is normal for your breast to be a little bit tender in the first couple days, and your nipples can be sore in the first couple days. What's not normal is extreme pain with latch or cracked, dry, bleeding nipples. And so what do you do when you start to notice that? First thing is, again, get on the phone and call your lactation consultant. And two, start to address maybe some of the causes of sore nipples. So I often see in my clinic that moms are putting lanolin cream or nipple cream on when they start to have sore or cracked nipples. And it's actually, we've moved away from using lanolin cream or kind of breast nipple creams in general for two reasons. One, in general, the medical field has moved away from wet dressings to more dried dressings for wounds. And so lanolin cream is an extremely moist environment. Two, creams in general will block some of the glands on the nipple and breast. So instead, what I usually recommend is putting a little bit of breast milk actually on your dry and cracked nipples. That has a lot of antimicrobial properties. And then two, keeping your nipples very dry. So keep them and let them dry out to air as often as possible. If you're having a lot of pain from your nipple rubbing up against your clothing, you can use a breast shell to try to alleviate some of that pain. Breast shells are different than nipple shields. Breast shells are just something that goes on the inside of a soft bra or your t-shirt to prevent that rubbing up against. I don't recommend ever initiating using a nipple shield without your lactation consultant, because nipple shields, again, when we're talking about supply, a lot of the supply is the stimulation you get from the baby touching your breast and areola, as well as the sucking. When you have a nipple shield on, there's a barrier between your baby and your breast skin. And that lack of stimulation can greatly affect your breast and milk supply. So I don't recommend using nipple shields unless you are using it in conjunction with your lactation consultant. And most lactation consultants will only use them for short periods of time while they address whatever issue they recommended for the nipple shield in the first place. So other things to think about if you're experiencing sore or painful nipples. One is you want to start initiating the feeding on the nipple that is less sore, because the milk letdown is often more extreme when you start breastfeeding, and so that can help a little bit with the pain. Two, you should think about trying different positions. There might be a position that's potentially more comfortable for you and baby that leads to a little bit less nipple soreness. Three, you want to potentially think about, if you do notice any of those things we were talking about earlier, the baby's lips are not pursed out, the latch is shallow, so the mouth is only open 45 degrees instead of 180 degrees, unlatching the baby. So again, taking your finger in the corner of their mouth and removing them from the breast and having them attempt to relatch again properly. And then four, you want to, again, try thinking about feeding the baby at the first signs of hunger cues as opposed to waiting later when they are frustrated and more likely to latch more strongly. So now I kind of want to talk about some of the most common breastfeeding myths that I have encountered. So the most common myth I see out there is that it's all or nothing with breastfeeding. So either you exclusively breastfeed or you don't at all. And that is definitely not the case. So you should take into account every mother-baby dyad and what is going to work best for them. And just because you don't exclusively breastfeed doesn't mean you can't breastfeed at all. There's pretty good research that shows even if a baby requires supplementation the first couple of days of life, that doesn't interfere with their ability to breastfeed or even exclusively breastfeed later on in their life. And there's also additional research looking at formula supplementation and does this affect the baby's gut microbiome if they're breastfed. And babies who receive formula while breastfeeding, their gut microbiome doesn't change. So all of this kind of shows us that all the great benefits of breastfeeding aren't negated by introducing formula. And that, again, parents and mothers should be encouraged that if they want to partially breastfeed and not exclusively breastfeed, that they are hopefully going to be able to do that successfully. I just recommend, again, that you have the right support in place so that you have some sort of lactation consultant, and that you've kind of thought about your breastfeeding journey ahead of time. So the next common myth I encounter is that if a baby is bottle fed, that they will not be able to successfully breastfeed. Bottle feeding a baby does not necessarily mean that they cannot breastfeed. Most lactation consultants will recommend that you wait at least 3 or 4 weeks before introducing a bottle, because by 3 or 4 weeks, most mothers have established a pretty good idea of how to breastfeed successfully and have had a successful milk supply established at that point. When you introduce bottle feeding to breastfeed babies, it can help if you do something called paced feedings, and it also helps if you continue to do both. So bottle feeding requires practice. Babies need to learn how to eat at the bottle. So I usually recommend that you do introduce the bottle at least one time a day, especially if you're a mother who's planning to go back to work and continue breastfeeding. You are going to have to bottle feed your baby your expressed or pumped breast milk. And so you want to get them used to and learn how to use a bottle at, around that 3 to 4 week mark. Another common myth that I see all the time and hear about all the time is that breastfed babies don't sleep as well or as long as formula-fed babies. And there is a physiological difference between breast milk and formula in that breast milk is about, and we talked about this in the formula episode, so breast milk is about 60% whey, 40% casein, versus bovine cow's milk is about 80% casein and 20% whey. And when casein, which is a protein, enters an acidic environment like the stomach, it often precipitates and forms kind of a solid. So you can kind of see that chunky white solid. If you've ever burped a formula-fed baby, that's often what comes out. And that chunky solid or precipitate stays in the stomach for longer, so it delays gastric emptying. But there's been many, many studies that show that there is no difference between when a baby first learns to sleep through the night, whether they're breastfed or formula fed, number of nocturnal feeds, or length of time that they stay asleep. And so this is really a myth and a misconception that babies who are formula fed, or if you mix formula into your breast milk or only formula feed your baby at night, that they will somehow sleep longer. The research just really hasn't panned out to show that. Another misconception or myth that I encounter frequently in my practice is that especially breastfeeding moms are super happy after delivery. And this is really all moms. So across the board, it's breastfeeding or formula fed. About 80% of mothers will experience what's called the baby blues. So that can look like stress, anxiety, sadness within the first 2 weeks after delivering their baby. So you have all these hormones coupled with lack of sleep and adjustment to your new baby, and we believe that's kind of what leads to the baby blues. Most of the time, this will get better on its own within 2 weeks. But if it's not getting better, or certainly it's getting worse, I definitely encourage you to reach out to your healthcare provider and let them know. So another kind of misconception, I think, especially for first-time parents or new parents, is that every time a baby cries, that means they're hungry. So the only way that a baby has to communicate with its parents really is by crying. And they use that to communicate all of their needs. So it can be that I have a wet diaper, I'm too hot, I'm too cold, I'd like to be picked up, I'd like a little bit of snuggling right now. And it does not necessarily always mean they're hungry. So what this kind of looks like is that the parent might say, my baby's crying and I put them to breast and they're not hungry. And that might be the case. They might be trying to communicate a different need. So I usually say in that situation, check the diaper, change them if it's dirty, swaddle and soothe them, or get them unwrapped and do some skin to skin, consider some baby wearing, look at the temperature and what clothes they're in, and try to kind of troubleshoot all of these other baby needs if they're crying but not hungry. This next myth is a favorite of mine. I often hear especially older generations tell their newer parents that you cannot nurse your baby to sleep, or you will spoil them, or they'll never need to learn to sleep on their own. So this is especially not true for newborns. Newborns are not really capable of forming sleep associations. So in those first couple months of life, it is absolutely okay and natural to nurse your baby to sleep. There are actually hormones, sleepy hormones that are produced in breast milk that are higher at night, and so it makes babies more likely to sleep after nursing. So if you want to nurse your baby to sleep, that's totally okay in the newborn period. Another myth that I kind of encounter a lot are questions about the cosmetic effect of breastfeeding on breasts. And again, this is an area where there's kind of been a lot of research lately that shows that it's not really breastfeeding that creates these changes. So it's fluctuations in weight, hormones itself, age, and genetics. All of these things play a role in the changes that we see in breasts as time kind of goes on. And none of it really has to do with whether you breastfed or not. Another common question I see a lot in the clinic are, does the size of my breast matter? So if I have super small breasts, am I not going to be able to breastfeed is usually how this is asked. This is a common myth. The size of the breast actually does not dictate how much milk is produced. Milk supply is really dictated by removal of milk. And so small chested or small breasted women are able to successfully breastfeed and make just as much milk as large chested or large breasted women. Really, the only difference that the size of your breast makes is in the positioning during breastfeeding. So, and relative to the size of your baby. So sometimes if you are a large chested or a large breasted woman, different breastfeeding positions might be more comfortable for you and for baby. Another common breastfeeding myth I hear, and I've heard this even during my training from other clinicians and physicians, is that breastfeeding beyond the age of 1 is really just for comfort and there's no nutritional value to breast milk, that it's almost like water. Again, this is a misconception and a myth. It's since been proven that breast milk continues to be nutritionally valuable well after 1. It still contains a lot of, again, nutritional content, but as well as immunologic content. And so there's definitely benefit to breastfeeding beyond the age of 1. The AAP recommends that you can breastfeed up to 2 years of age. And so again, this is really about mothers following their instinct and what's best for them and also what's best for their baby. So don't negate as a mother what's best for you. At some point, if you feel like you no longer want to breastfeed, that's a great reason, and certainly the number one reason to start transitioning your baby off or weaning them off of breast milk, but not because there's no nutritional value to it. Another common myth I see in the first couple days of breastfeeding is that that you can pump and figure out how much breast milk you're making, or that you can do pre and post feeding weights. I never recommend that parents do pre and post feed weights at home. This is something that really should be done by a physician or in a pediatric office if they're being done. And then pumping, babies are actually much more efficient at removing breast milk than even hospital grade pumps. And so pumping will often underestimate how much milk you're producing. So if you pump and you're not seeing a ton of milk, don't be concerned. The way that we tell that babies are getting enough breast milk is by A, how many wet diapers are they making? B, in those first couple of days of life, how many stools are they making and what do those stools look like? So are they going from that thick black meconium-like stool and transitioning to a more yellow CD mustardy stool? And lastly, weights. And again, when it comes to weights, I strongly recommend that patients do not weigh their children at home, that they wait and follow the guidance of their pediatrician. If your pediatrician is concerned about your newborn's weight, they will bring you back to reweigh them and they will certainly tell you and let you know about it. So absolutely don't pump just to see how much you're making. Again, pumping is not the same as a baby at the breast. It's not as efficient, and it actually is not as stimulating as the baby at the breast. So it can actually affect your milk supply. So I strongly recommend that you don't do that and that you don't do newborn weights at home or pre or post feeding weights. Another kind of myth that's usually addressed by the OBGs is that breastfeeding prevents you from getting pregnant again. It can certainly decrease in the first 6 months your ability potentially to get pregnant, but it's absolutely not 100% or even close to 100% effective. And so you really should, if you don't want to get pregnant again, consider alternative methods of birth control outside of breastfeeding. So another common myth I see in practice is that you have to pump and dump. So absolutely don't. This is kind of where a mom drinks alcohol and then they pump their breast milk and throw it out. Absolutely don't ever throw out your breast milk, please. So the American Academy of Pediatrics, or the AAP, recommends that if you've drank an alcoholic beverage, so that's 1 4-ounce glass of wine or 12-ounce beer, for example, that you wait 2 hours before you breastfeed your baby. If you have more than that, you wait a little bit longer. And so I usually recommend, if you're going to go out and do that, think about potentially pumping in this situation to have some milk available in case your baby is hungry. But under no circumstances do you need to pump and dump your milk. Another common question I get is that if you're on certain medications that you cannot breastfeed. So there's actually very few medications where there is an absolute contraindication to breastfeeding. And if you're on a medication, you're considering getting on a medication, you're concerned, you can go to LactMed or infantrest.com. You can even call 806-352-2510 and ask about the medications you're on, and they will let you know if you have a contraindication to breastfeeding on those medications. But by and large, there are very, very, very few medications that you cannot breastfeed on. And then kind of the last myth that I see is sometimes I have moms ask me if they breastfeed in public, is that illegal? So somehow is that indecent exposure? This is 100% not true. Breastfeeding in public is absolutely a protected right. If your baby is hungry and you're in public, you should absolutely feed them and not feel like you cannot do that for some reason. So I guess with that last myth, I just want to reemphasize breastfeeding is an extremely personal decision. If you are considering breastfeeding, you should get a little bit of education about it ahead of time so that you're kind of prepared. I do recommend having a lactation consultant lined up within the first 48 hours of birth just to help you through these first couple days, because the evidence really shows that if a mom is going to stop breastfeeding, she's most at risk for this actually between the time she leaves the hospital and the first pediatric visit, mostly probably because of lack of support and knowledge during this time. So help yourself by getting a bridge or a support person with education during that time period, like a lactation consultant. Have good support in place, whether you're breastfeeding or not. Having a newborn is an incredible adjustment. You're going to be sleepy, you're going to be tired, and you're going to want and deserve support during this time. I hope this video gave you a couple of tools in your pocket if you're thinking about breastfeeding and you're pregnant, and I hope you found it useful.
Thank you for watching the Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com, and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.